For millions of our seniors, access to Medicare services is only as good as the payment policies behind them. And when those policies fail to keep pace with modern care delivery, patients feel it first through delayed services, fewer provider options, and reduced access to care in their communities. Across the country, providers are telling us the same thing. Outdated reimbursement rules and rigid payment schedules are making it harder to deliver care where patients need it the most, which is at home, close to family, and outside of institutional settings. And with that, Mrs. Sullivan, my district covers a large stretch of rural communities where a simple infusion appointment can easily turn into an all-day ordeal for patients and caregivers, family that have to be responsible for transportation. And in the winter especially, I represent Western New York and the southern tier of New York where it's a harsh winter. Weather and road conditions can make repeated trips to a hospital outpatient department unrealistic. And missing doses isn't just inconvenient, it can derail the treatment plan of a patient. When Medicare doesn't make the home option dependable, the system too often defaults patients into a more inconvenient setting simply because it's the only workable way to complete their treatment. Mrs. Sullivan, can you explain how the Preserving Patient Access to Home Infusion Act would help keep Medicare patients on track with treatment for patients that are long ways away from their next hospital campus or infusion center so that their care isn't determined by weather or logistics, but by what their doctor believes is safest for them?
Thank you, Congressman, for the question. Home infusion operates on a model that is incredibly efficient in that we rely on the pharmacy to provide that support, the continuity of care for patients so that they can independently infuse their medications at home. They don't rely on a nurse regularly. The nurse visits periodically to make sure things are on track, to lay eyes on the patient. Maybe they have a wound or something that needs to be assessed to make sure it's healing properly. But the support really comes from the pharmacy on a daily basis and largely happens behind the scenes. The Medicare program's benefit is so fragmented, which was confirmed by the GAO report that I mentioned in my opening remarks, that they pay for only the services that happen in the home, which are the most infrequent of the services that occur with a home infusion patient. So the pharmacy is working behind the scenes, communicating with the physician, monitoring labs, making sure everything is working properly for that patient and can communicate with them without the patient needing to travel, without needing to send resources to the home. So it's an efficient model that has been widely adopted in the commercial market. And you would think with almost 1 million beneficiaries under the Medicare program being sent to hospital outpatient departments for these infusions, that hospitals would not want to lose that business. In fact, most health systems have signed letters of support of this particular legislation because they recognize these are not patients that need to be there, that they have other patients that would better benefit from their resources. And so it's one of those common sense solutions that helps patients, helps our health systems, and uses appropriate resources.
Key word is common sense. Ms. Vandemeter, as you know, Medicare lab payments are still based on outdated data that fails to reflect real costs. And in just 25 days, labs could be hit with the payment cuts of up to 15% across hundreds of tests, making it harder to deliver timely and accurate care. What are some of the unique challenges that these payment cuts create for labs serving rural communities or other vulnerable populations like those in nursing homes?
Thank you for the question. The infrastructure that exists in rural or frontier communities may not be as robust as is ideal. Right now, we have patient service centers, there are hospital laboratories, physician office labs, and obviously large commercial labs that have capacity to move samples around the country. But if the cuts go into effect, we worry that that infrastructure will be compromised. Fewer patient service centers, smaller menus, longer turnaround time. We need those tests to be timely in order to make clinical judgments about the right pathway for care. So we are concerned about patient access to those services across the country, but certainly in rural and frontier communities.
Thank you. I'm a proud co-sponsor of the Results Act, which is a common sense fix to prevent these payment cuts while reducing the administrative burden on laboratories and CMS. And finally, Mr. Ryan, last year, AAA Home Care conducted a survey on the impact of the 2024 payment cuts on durable medical equipment. Could you briefly summarize your findings in the remaining time?
Hold on. We discussed this earlier today, Mr. Congressman, but certainly When those 75-25 rate cuts went into effect, again, this is in the non-rural, non-bid area of the country, that when they woke up overnight and just saw a 50% cut, 75% cut, and we had Congress intervene twice to make sure those cuts were not in place, and the 75-25 rate remained in place. Well, since they've stopped, key findings are that 65% of the products have been reduced. The companies are offering fewer products. 46% reduced their service area. 53% laid off staff. 35% used personal savings to maintain the business. And 1 in 10 surveyed said they'll be entirely out of business within a year.
Well, thank you for bringing that up, and I yield back.
Gentleman yields back. We now enter